Oh yeah, I don't have any conflicts of interest. Um, is anyone in here old enough to have seen Nurse Jackie? It's true. Nurse Jackie was kind of true. And substance abuse is one of the occupational hazards of nursing. So why would that be? Anybody?
Stress and the things that they see.
Stress and things that we see, yes, it affects us all. Um, we also have access that the public doesn't have. We have access to the good drugs, like Dilaudid. It's one of the favorite drugs. If y'all go on and should become a nurse anesthetist, um, their favorite drug of choice is fentanyl. I don't know how they can do that, but they really have to learn how to titrate that so they're not falling asleep. So these are known occupational hazards of nursing. Y'all have probably talked about this. Back injuries. I know when I talk fundamentals, I used to talk about back injuries a lot because nurses are prone to back injuries from pulling patients up in bed, helping them get out of bed. Needle sticks, still a problem sometimes. Exposure to virulent organisms. Lesser known but more fatal, substance abuse problems. This is a hazard of a PowerPoint. That's why I don't turn the lights down. So in 2023, which is the last published statistics that we have, people aged 12 or older had 17.1% had a substance use disorder in the last year, which also includes alcohol use. That's considered a substance use disorder. Prevalence in nursing is similar, but likely higher due to our access. It's estimated that 250,000 nurses are impaired by substance use disorders. So, when you have to go to the hospital, and we all have to go to the hospital sometime, most of y'all are young, so you're probably not looking forward to going to the hospital soon. But do you want your nurse to be on drugs? No, you don't. You want your doctor to be on drugs? What about your surgeon? No, we don't want that. So we in Louisiana, oh, here's another thing. How many of you think Louisiana's backward? It's okay. You can tell me. I think we're backwards in a lot of ways. Louisiana was the third state in the nation to have a recovering nurse program so that nurses could get treatment instead of losing their license. These things are different about treating healthcare professionals. That healthcare professionals are educated. I mean, we give drugs all the time. They think that their education is going to protect them from becoming addicted. Now, y'all may be thinking, two of us. I know which two those are, but not necessarily, because when you're in college, then sometimes that's just a time for experimentation. And not all people who have, who seem to have a problem are drink a lot or maybe use drugs in college. Not all of those people develop a substance use disorder. Of course, we administer controlled substances. We have access to drugs which the general population does not have. Nurses suffer from repeated trauma. Now, as Dr. Alexander said, I worked for a long time in psych. And so it was traumatizing for the staff and for the patients if we had to put someone in restraints. But in psych, we realized that we should work on our own mental health. And so at my hospital, we used to have debriefings after we had some kind of incidents with patients. But if you're, how many of you want to work in the ER? Adrenaline junkies. Okay. Uh, um, those people who work in the ER don't ever take time to debrief. You know, their patient comes in terrible shape. Sometimes they die. Sometimes we're unable to help them, but no one talks about it because you have to move on to the next patient. And so we have repeated trauma. If you work in the NICU, if you work in the PICU, sometimes the children die, and that's an emotional problem for nurses because we went into nursing to help people, not to watch people die. And so another thing that nurses do is we are doers. We want to take care of everybody and everything. Um, and sometimes we don't take care of ourselves. We try and fix other people, but we don't fix ourselves. Okay, so there are still some people who don't believe that addiction is a disease. But I believe that addiction is a disease. It's a primary disease. It has a genetic predisposition. They they did a study of children of alcoholics, actually male children of alcoholics. You know, a lot of studies are skewed toward males. And they found that for men, if one of your parents was an alcoholic, you were 4 times more likely than the general public to become an alcoholic. So there's a genetic predisposition. It's progressive, ongoing deterioration marked by early, middle, and late stages, and we're going to slightly cover those in just a few minutes. It's chronic. It's a relapsing medical condition. But as I told my nurses when I was working for the board, relapse can be an expected part of this disease, but you don't have to relapse. Now, I have a little bit different philosophy than Dr. Alexander because she said that the person has to want to get better. But in my experience, sometimes we forced nurses into treatment, and in order to keep their license, they would sign a contract with us that they would do this, this, and this, and we'll go over that in a minute. And I can't tell you how many nurses came back to me near the end of their program and said, I wasn't going to stop using. I went into this program to save my license, but we require that they go through the steps of recovery. And sometimes it takes, in spite of their wishes. You know, one of my very dear friends who graduated from the program said, I had no intention of staying clean and sober, but I got into meetings and I got a sponsor and all those things y'all made us do. And now I just can't imagine going back to using. So I really loved working with the nurses when I was working with the Recovering Nurse Program. Of course, we don't think about this, but addiction is fatal if left untreated. Either we wind up in institutions, jail, or dead. There are some differences to treatment here. I'm not going to really go over those. Well, I will a little. Doctors, you know, if they come into treatment, think they already know it all. Nurses come into treatment. Now, y'all are studying psych patients, and so you probably have talked about manipulation. And so you probably talked about manipulation not in a good sense, right? So, but we as nurses become manipulators because sometimes we have to manipulate people to get what we need for our patients. Manipulation's not always a four-letter word. You know, it can be used for good, but nurses might come into treatment and might need treatment, and they're used to manipulating people. And as you finish up this semester, you'll find out about borderlines and manipulative behavior and how it drives people crazy. But what we do as nurses is not always a bad thing. You know, you have to call the doctor at 3 a.m. and you might say, you don't say, Doc, this patient needs an antibiotic. No, you're going to say, well, doc, you know, the temperature is high. They have an elevated white blood cell count. Do you think that this patient could use some antibiotics? Because if you call them up and say they need some antibiotics, they're going to go, yeah, and where'd you get your medical degree? So manipulation is not always bad, but nurses can be manipulators, and it can be a problem when they're in treatment. This is the Jelinek curve. This is not of my making, and I don't know if y'all can read that, but this is the cycle that addicts go through, addicts and alcoholics, and it's been around for a long time. And it tells you down here, your obsessive drinking or using, uh, it continues in vicious cycles until the person either gets into recovery, winds up in an institution, or is dead. Denial. I heard Dr. Alexander mention denial as I was coming in. Denial is not a river in Egypt. Okay, that was supposed to be funny. Maybe y'all have already heard that, but they talk about that a lot in recovery circles, that denial is not a river in Egypt. It's what we do. We deny there's a problem. Nurses are smart. They know the effects of drugs. They don't believe it can happen to them, and they don't believe it's a problem. Well, you know, most of the nurses who came into the Recovery Nurse Program were stealing drugs from work. And so, do you think that's a problem if you're stealing drugs from your patient? Well, we are in our right mind, so we would say, yes, that's a real problem. I had a nurse tell me one time, this was a registered nurse, and she was digging through the sharps container because there was part of a vial of Dilaudid in there. It's a registered nurse. She's digging through the sharps container, and she said it wasn't a problem. So people can have all kinds of denial, you know. Um, but that was a problem, just in case you're wondering. That's a real problem. Okay, why should nurses be treated with nurses? Are we the most trusted profession? Yes, we are. For about 18 out of the last 20 years. I think, or maybe 19, I think the firefighters got the most trusted profession the year of 9/11. But anyway, um, this is it. Nurses who have diverted drugs for their own use have already violated their own moral and ethical code. Because if we're in our right mind, we're not going to take the drugs that were meant for our patient. Nurses are filled with guilt and shame, and that makes their denial even higher. And we probably don't want to share in a general, open, public type group that we were stealing patients' medications, because then every time a person is a patient in a hospital, they're going to be wondering if their nurse is stealing their drugs, and we don't want that. And nurses, they need to be with an experienced therapist. Nurses are used to being in charge. Nurses will take over a group before you can say Jack Rabbit, although they've never had any experience running a group before. Nurses try and dictate their own treatment, and they also try and take care of everyone else in the group rather than working on themselves. It's much easier to work on other people than it is to work on ourselves. So nurses need long-term inpatient treatment, and Dr. Alexander mentioned 28 days. We really like for our nurses to go for 90 days. 28 days, you're barely clearing from the fogginess from detox. And the longer that we can keep that nurse, people go, can't afford 90 days. I can't leave my children. Well, who's going to take care of your children when you're dead because you were using? But we did find that we had a much better recovery rate with nurses who went to 90-day treatment. And the longer you can keep a person, any person, but the longer you can keep them away from that drug of choice, then the better your outcome is going to be.
Yeah, now remember when I'm talking about general public, everybody else. So she's, it's hard to get insurance to look at anything outside of 28 days, but.
And it's hard to get insurance to look at 28 days. They want patients to do outpatient treatment.
Right.
Well, then a person goes to treatment for 3 or 4 hours a day, maybe in the evening, and they're still with the same people. They're still tempted to use because they just go to treatment, they go to work, they go home, and there's nothing to keep them from using, really. Outpatient treatment is, I won't say it's worthless, but when I was with the Recovery Nurse Program, we treated over 3,000 nurses, and I only remember one who went through outpatient treatment who didn't relapse. And your insurance will say, you went to outpatient treatment and you relapsed, and your insurance company is going to say, well, we paid for treatment, we're not paying for it again. So do they say that to diabetics? When diabetics come back into the hospital, we have a lot of diabetics who come into the hospital repeatedly, but they are never denied coverage. Even though I like to compare addictions and diabetes, because they both, have that element that we need to keep up our own treatment and take care of ourselves so that we don't have to come back in for more treatment. Okay. This is what you'll hear from people in the throes of their addiction. See, this poor crayon is down on the floor, but you said, no, I'm fine. I'm fine. Really, I am. Okay, molecular structures. Hydrocodone, oxycodone, heroin. The central molecule structure is identical. Y'all know the story of heroin? I love my story of heroin. You see this, you see there, maybe I don't know if you can read it. Heroin was sold over the counter. It was made by the Bayer Company, Bayer aspirin. Um, Heroin was invented in the late 1880s as a cure for morphine addiction. See how well that worked out? Because especially, well, in Asia, it was fine and dandy to have not heroin, to have morphine places where people just went and smoked morphine, shot up morphine. And in the States, we got into some of that because we had so many injured soldiers after the Civil War that came home and they still had a lot of pain. And so morphine addiction was just rampant. And so heroin was invented as a cure for morphine addiction. So, y'all think about that when you're treating a person who is addicted to opiates and they have them on
Methadone?
well, methadone is one of them, but we have a newer one. Sorry, my mind went blank. That happens when you get old. Suboxone. Suboxone is an opiate, and we're treating an opiate addiction with another opiate, just like we were treating morphine addiction with heroin. Now, that's my own personal bias, but that's how I view things. And if you are, because I was good friends with a doctor who had been an addict, and he was on Suboxone, and he said he didn't have any feelings. It was just a numbing. It was a different kind of opiate. And so I don't really think that, I think it has a place, for people who are on the streets and they're breaking into homes and stealing so that they can support their habit. Maybe Suboxone is a good treatment for them. But if we don't want nurses coming to work on Suboxone, and in some states they are allowed to do that. But to me, it's another, they're dull, their senses are dulled. But then I had a doctor to tell me that his nurse could return to work. She had back pain, and she had a morphine pump, and she was doing home health. And I didn't think the nurse should be driving, much less nursing, but you can find someone to say it's okay. These occupational risk factors. A lot of our nurses, work in high stress. They're single mothers. They have back injuries. And so sometimes we may start using drugs because they were prescribed to us. A lack of external control. Now, sometimes if a person has a broken bone, a doctor will prescribe Vicodin or something along those lines for people to take at home. And then the person needs more, to get the same relief, and they become addicted. And so then the doctor says, well, no, you shouldn't still be having pain 6 weeks after you got your cast off, so I'm not going to give you any more. Okay, well, they've been getting their Vicodin or whatever through the pharmacy, and their insurance is paying for it. But they find that you can buy it on the street. Well, does anybody have any idea how much one pill would be if you buy it on the street? You don't know? That's probably a good thing. It would be about $10 a pill. Maybe higher today with inflation. I don't know. Um, and so that could get expensive if you were taking 10 a day, right? And so if you can get the same relief, the same high from heroin that you buy on the street, how much do you think the heroin cost? About $3. So some people transfer from legal prescribed drugs to heroin. Uh, when I was with the Recovering Nurse Program, I only remember two nurses who were addicted to heroin. One had been addicted while she was a student. She went all the way through school addicted to heroin. And today she's a family nurse practitioner. She was the president of the Family Nurse Practitioner Association, so that you can do very well if you get into recovery. What can you do? Educate yourself. Recommended reading and becoming a nurse. The Shunt Survey. Please take care of yourself. If you suspect a colleague is impaired, you should report them to their supervisor. If nothing is done, then you should go up the chain of command, because some people don't want to interfere with their friends' lives. So here's the purpose of the RNP: identify and assist impaired nurses, provide statewide identification, educate healthcare providers and the public about substance use disorders. You can come into the RNP without disciplinary action against your license, meaning that it's an alternative to disciplinary action. Sometimes it's part of a stipulation on your license if there have been previous problems. 70% of disciplinary action taken by boards of nursing are related to alcohol or substance use disorders. Oh, y'all can't see this. I'm sorry, cut the bottom off. But when I was over the Recovering Nurse Program, this first column that you see was alcohol. Second, third, we had marijuana. This fourth one was opiates. So we had, more than 50% of our nurses were addicted to opiates. These are general program requirements. They have to go to treatment. They can't return to work until they're cleared by the addictionologist. They have to attend meetings, AA meetings or NA meetings, and RNP support groups. We have RNP support groups all across the state. And it's just made up of registered nurses who are in the program. They have to have complete and total abstinence from all mood-altering chemicals, and we do have some work restrictions and require reports from the employer. So what are the warning signs? We have different warning signs for alcohol and for nurses who are stealing drugs. Of course, the alcoholic nurse, y'all may have come in contact with alcoholics before, and they have mood swings. They have a lot of excuses. Sometimes they don't take care of their personal hygiene. Blackout phone calls. Have any of y'all ever gotten a call from a drunk? when I worked at River Oaks, we had to take turns taking incoming calls, and it's just impossible. I mean, you feel like you just want to go. I can't listen to this anymore. Um, but yeah, but that's a very common thing. Uh, they're withdrawn. Sometimes they're going out to their car for their breaks uh, or for lunch, where they might be uh, having something to drink. The, and the alcoholic nurse calls in a lot. Maybe she wakes up and she has a hangover or whatever. Um, your person who is stealing drugs from the hospital um, never calls in, because that's where they're getting their drugs from. Um, when I was at Big Charity, we had this nurse, this male nurse in SICU, and he was a wonderful nurse. He was really a great nurse. He could work circles around most people. And we never suspected that he was addicted to drugs until he started coming in on his day off to help us give meds. So you'll see some behavior out there. Uh, Job performance changes, job shrinkage. What does that mean? Most nurses who become addicted were very good nurses. Uh, the majority of them finish in the top third of their class. And so they're used to working circles around people. And when they start using, their work performance may fall off, but then they may only look average, you know? So that's job shrinkage. Illogical or sloppy charting. We don't have that anymore because all of us are charting by computer. But it was really interesting because I started working with nurses who were addicted 30 something years ago, and they're charting. And it'd be sliding down the paper. You couldn't read it at the beginning of the shift. It's okay, but by the end of the shift, you don't know what they're saying. Um, Spilled or broken controlled substances. Now, I've been a nurse for over 50 years. I never broke a vial unintentionally. But nurses will have 3 or 4, or they drop it and they say it's shattered, but we don't know where it shattered because we didn't find any glass anywhere. Uh, so they will have a lot of excuses. Now, I'm not saying it doesn't ever happen, because you will find sometimes that it actually does happen, but not that often. Okay. Nurses in Louisiana, you have a legal and an ethical responsibility for reporting nurses under suspicion or identified as having a substance use disorder. And that's why one of the reasons we have this recovering nurse program. So people didn't want to report their friends, if they knew their friend was just going to lose their license. Sometimes administration didn't want to report nurses because um, of whatever problems they think might come up. But when I was with the program, we had a nurse that happened to be here in Shreveport, and she was stealing drugs, and they knew she was stealing drugs, so they just fired her. And she went on down the road. She went over to a hospital in Texas and started working. And she was responsible. What she was doing was calling the doctor saying, this patient is not getting pain relief. And can we up the dosage? And so, it's a high dosage, but the patient wasn't getting it. And so you have this big dose, and she was stealing it. And the next shift comes on and sees this high dosage, and the patient says, "Listen, my pain is not any better. Can I get my pain med?" Well, they hadn't had any pain med, but the nurse coming on didn't know that. So they give them this big dose of opiates, and it causes patient death. And the family found out that she had been fired from the hospital here without being reported, and they sued that hospital. Now, this was years ago, but things like that can happen. It's not, that's why we have our law that we have to report it. Now, you as a staff nurse don't need to confront your coworker. You need to go to your supervisor. If your supervisor does nothing about it, then you going up the chain of command. If no one wants to do about it, you can call the state board. You can call them and tell them what you see. But that shouldn't be your first step. Nursing is a privilege. It's not a right. This is just part of the law. And y'all, are y'all familiar with the Board of Nursing? The Board of Nursing is the licensing agency. And sometimes people get the Board of Nursing mixed up with the State Nurses Association. The State Nurses Association is there to protect the nurse and work with the nurses. The board is there to protect the public. Okay. So healthcare professionals are difficult, but not impossible to treat. My last 3 years at the Recovery Nurse Program, we only had a 3% relapse rate. And most of our nurses graduated and went on to do great things. So, if you can't read that, it says, "Dear God, when will this presentation end?" Have any questions? I get a little carried away because I know not everybody gets excited about treating substance use disorders, but I saw so many nurses that actually got into recovery and stayed in recovery, for 30, 40 years. And I worked with a great doc who now has over 40 years of recovery. So it's just really heartening to me to know that people can get over this disease. And I wish that we could translate that all to the general public. And I actually think we could if we wanted to, but no one wants to spend that money. Okay, I'm sorry. Any questions? Well, thank y'all very much. Dr. Alexander is going to have these slides to post. And if y'all have any questions, you can, of course, I'm in the clinic now. I'm your health services nurse. You can always stop by and ask me. We have lots of information about addictions. Okay. Any questions from Alexandria? They may have left.
No, ma'am, we don't have any questions.
Okay, thank you.
You're welcome. Thank you.
Okay. Well, if there's no other questions and y'all are good about the content up till now, y'all are free to go. Thank you.